I am thrilled now to introduce Dr. Michelle Mosier. She's going to be talking with us today about Tennessee Centers of Excellence for Children in State Custody, system collaborations to address child maltreatment. Dr. Mosier is a licensed clinical psychologist and professor in the Department of Psychiatry and Behavioral Science in the Quillen College of Medicine. She has served as the director of ETSU's Center of Excellence for Children in State Custody since 2006 and has been a psychologist with the center since its inception in 2002. Dr. Mosier has been part of the COE Best Practices Collaborative Leadership, which has worked together since 2007, implementing approximately 10 learning collaboratives with 4 different evidence-based treatment models. She co-led the Tennessee Infant and Early Childhood Mental Health Initiative from its inception in 2010 until 2016, when the group formalized to become the Association of Infant Mental Health in Tennessee, or as it is fondly known as CFHI Tennessee. She served as president of the founding board of directors for CFHI Tennessee and currently serves as a board member and as the board liaison to the CFHI Tennessee Advisory Council. She was recognized this past year for her tremendous leadership role in elevating the concept, the issue of infant mental health and really bringing it to the forefront. She has also been a member of the Tennessee Young Child Wellness Council and the Council on Children's Mental Health. Here at ETSU, she's one of the leaders of the Ballad Health Strong Brain Institute and is also a key part of the founding leadership group for the Child and Family Health Institute. She completed her PhD and MA in clinical psychology at Miami University, did her clinical child internship at the University of Louisville, and I can say Louisville because my mom spent time in Louisville, School of Medicine, Department of Psychiatry and Behavioral Sciences. And then prior to relocating to Tennessee from Ohio in 2002, she worked in private practice in a rural area treating children and adolescents. So that's a little bit about Dr. Mosier. And again, thank you, Michelle, for being here with us today. You know, we always like to make these sessions as interactive as possible. So if at any time you do have questions or comments when Dr. Mosier is speaking, feel free to, you know, put those in the chat and we'll help you monitor those, Dr. Mosier. So I'll turn things over to you.
All right, thank you. And you made me tired. I don't know if I can do this talk now, all that stuff. I'm getting old with my Vita has all that stuff on it. Let's see, I practiced so I would be able to do my screen share. And yay. So I'm glad to be here, but I also am not a fan of being the person in front of the room. I really like more about all the collaborations, as you can see, and all the group work, but it really is a privilege to get to talk to you all about the Centers of Excellence for Children in State Custody, both what we do statewide and what we do locally. And I always feel like that's one of those things about the elephant, right? Like, so people might know one thing that we do, but they don't know the other thing because we do so many different things. So it's a nice opportunity to kind of put the whole thing together. I don't have any disclosures, but I would like to say this presentation is the collaboration of all of the COEs. We've put these slides together for other talks, and so they are not my own, but are part of the COE. So because it was a CME presentation, had to have some learning objectives, but on the whole, I really just want to talk about what the COEs are, some of the dissemination work we do, and some of the system development we do in the state of Tennessee. So to ground us, I thought I would, I made up a story but it's a realistic story of a kind of a referral that the Center of Excellence would get. And we always have to remember that our role is as troubleshooters and helping with complexity. So this isn't to say that the Tennessee Department of Children's Services don't do good work. It's just that our role is when kids are not getting their needs met. So this is a mishmash of a lot of typical kinds of referrals we get. Now, I'll call her Olivia. Olivia is a small for age, 3-year-old developmentally delayed girl who was brought into state custody 2 months ago and had 3 disrupted foster home placements. Olivia was aggressive, hitting other children in daycare and the foster homes. She reportedly had injured the family dog in one of the previous foster homes. She was non-compliant and had what the foster parents had described as meltdowns that could last up to 2 hours. She cried a lot, was up late, often didn't fall asleep. If she did fall asleep, she would be up in the night walking around the house. After supervised visitations with her mother, Olivia's behavior seemed to get worse for several days before she'd settle back into a routine. In her last placement, the foster parents disrupted the placement because the child care center had asked them to remove Olivia because of her externalizing behavior problems. And both foster parents worked and were not able to stay home with her. Reports were that Olivia's biological parents had substance use disorders. They had a volatile relationship, and the police had been called several times to the home for domestic violence. At age 2, Child Protective Services had investigated a drug-exposed child and neglect allegations after the parents went to jail. Olivia went to live with her grandmother as a relative placement to avoid state custody. At age 3, Child Protective Services was called again for allegations of drug-exposed child, lack of supervision, and neglect. Olivia's grandmother was found to be positive for methamphetamine and had not followed through with the early intervention referrals that had been made by her primary care physician. Olivia was reportedly prenatally exposed to multiple substances, including prescribed buprenorphine, cigarettes, and alcohol. Her speech was difficult to understand, and she had difficulty communicating her needs. The DCS regional psychologist, would be Dr. Wyke, participated in a child and family team meeting and about the disrupted placement and suggested that the family service worker make a referral to the COE. So that's a heavy duty case. That's a lot of the complexities that we get, but I wanted to kind of ground when I go through kind of what the COEs do in a child's story so that it makes sense. So the COEs are a statewide network that's dedicated to improving services for children in custody or at risk of custody. And they can be both children involved with child welfare, child protective services, and with juvenile justice. Those are all children that are in the Department of Children's Services purview. These children are more likely than their peers to be victims of abuse, neglect, often with physical and developmental and psychiatric disabilities. There are complex children and often have a lot of, if you're talking ACEs, they often have lots of ACEs, and so do their families. This is just a map that shows there are 5 of these centers, and we're up in Northeast, and we serve the DCS region, the Northeast region, which is 8 counties. But there are 5 centers, one in Memphis, and one in Middle Tennessee, one in Chattanooga, and one in Knoxville. And we're all separately contracted to do similar services, but we work collaboratively together for some of our projects. So this is a celebration. The COE started, as Dr. Skadsina said, in 2002. They came to be, it was a great brainchild of the state when there was a lot of problems with child welfare, and there were problems with kids with TennCare getting services. And they came up with this, it's one of the responses that when there was 2 lawsuits, this idea of these centers that would be in academic centers to be consultants and help child welfare do their work better. And so when we first started in 2002, it was a 3-year grant. And here we are 20 years later, we've really become an important piece of the infrastructure. Although I'll say, not very many people know that we exist. If you work with child welfare or the community mental health system, folks know about us, but other people really don't. So we're just going to celebrate that this is a great thing that Tennessee has done and continuously funded. We're funded through TennCare dollars, and right now our contract are through Blue Care of Tennessee. So these are the counties just that my COE covers. And when we sometimes have kids from other regions that are placed in our county, and if they're having trouble, that we typically would be the ones to help the workers, even though the workers might be in Nashville. If the child is placed here, our COE typically does the work. These are the folks that work here. A lot of really, really old pictures, but I always like to show what our staff is because we do a lot of stuff. And when I start talking about it, and we have a very small staff. So there's me, I'm a psychologist, full-time, I'm the director, and we have Dr. Martha Bird. Many of you know she's a child and adolescent psychiatrist here in the Department of Psychiatry, and she's our consulting psychiatrist. And she works about a day and a half with us. Newly, we have Dr. Julia Thompson. It says Julian. Sorry, Julia. I'm doing this late at night. Julia Thompson. She just joined us in the beginning of the year, and we're looking forward to being able to do more services because we have a new full-time person, and it's our first new position in 20 years. So we're really excited. Erin Britton and Jenny Hodge. Erin Britton is the person who does all of the coordinating for us, getting all the records. Jenny's our social worker. They're full-time. And then Jan Royston, many of you know Jan from lots of emails and lots of support for keeping us organized. And then we have two part-time temporary people in the ETS lingo, but Dr. Tammy Kitchens is our consulting pediatrician. Many of you know her, Riverside Pediatrics and Elizabethton. She's been our consulting pediatrician, I think, since 2006. And she does record reviews for us for kids with complex needs. And then many of you also probably know John Paul Abner, whose full-time gig is a Milligan University professor, but he's also a global trainer in an evidence-based treatment called parent-child interaction therapy. And he has had a small contract with the COEs through our COE since about 2006, I think. So you can see people that do this work are really dedicated, and we really appreciate it. This slide is my colleague John Ebert did. When I read Olivia's story, it can sound overwhelming. Can't get what she needs. So many challenges, and this idea that we can't solve everything, but the pieces that we do have a ripple effect, and we don't know how far some of the interventions are going to go. So it keeps us grounded to know that while we can't fix everything, the things that we do make a difference for the children, the family, the workers, and for the system. So just to get very concrete, what does a COE do? We have across all of the COEs, we have core services we do. And these are consultation and direct service. So one of the things that we often say is the best thing that we do is to have the luxury of being a grant and to be able to do record reviews for these children with complex needs who may have had a lot of specialty care, a lot of assessments, and lots of placements and treatment. And so when they come to us, we have the luxury, and Erin is our go-to person to get every record of that child, health, legal, mental health, and pull all that together into a record review for a cohesive story. And many of our kids do not have a cohesive story in the child welfare system. They may have had folks come in and out, and the way that records are kept, every episode is different. And so there isn't a place where you really see from birth to now of what that child's story is, all the services they've had. So it's a lot of work, a lot of person power, but it sometimes becomes the most important piece of what we do, because we get to see what's been done, what's been missing, noticing where the gaps are. And sometimes this is the communication for the whole team about what that child needs, or it has been identified, but it's not been followed through with. So it's a really important piece of what we do. And nobody else can do that because, we're grant funded, so we can take the time we needed, whereas a mental health center really doesn't have the time because that's not billable time, right, to be able to do that. So it's an important piece. We do multidisciplinary staffing, put our heads together, talk with Dr. Wyke, think together with our psychiatrist. What are some of the things that we could do right now that could help them? What are some of our thoughts? When it's more complex than just kind of linking folks up with referrals or coordinating some of the things that have already been identified, we do case consultations. Again, getting all those records, bringing everyone together to understand what the problem is and maybe hear from each other what's going on. And so folks get on the same page and then come up with a better plan to move forward. Other COEs have been doing targeted psychological evaluations to fill in the gap when a service can't be accessed. COEs are not set up to be the providers of first line, be providers of first choice. We are kind of to fill in gaps. And I'm really excited. I've never been able to do this before because I was only one person. But now that we have Dr. Thompson, we are going to be looking at how our COE can also offer some of these targeted psychological evaluations when we can't access them in the community. We do comprehensive psychiatric evaluations with Dr. Bird, and what that means is that we get the record review. We do a team meeting with all of the providers and DCS to ask questions, get folks on the same page, try to understand where the questions are and where we might need to go. Then Dr. Bird and Jenny do individual interviews with foster parents, bio parents, and a play interview with the child, or a teen, it would be an individual interview. But we take all of that information, we get behavior checklists from teachers and from schools and get additional information. And then we pull the team back together and say, here's our thoughts. What do you all think? And kind of come up with a comprehensive plan and some action that the team can take. We do very limited treatment. Every once in a while, we might do brief medication management of a child with complex medication needs. And if our psychiatrist, Dr. Bird, can see that child more frequently than they can in the mental health center, a typical psychiatric appointment for us is an hour and a half, where we talk with the team, we talk with the caregivers, we talk with the child. Whereas, in the community mental health center, they have 30 minutes. We can do more in-depth work, again, to try to get that child stabilized in their placement, in their school setting, to avoid them having to have moves and to move them forward towards our unification goal. And every once in a while, the COEs do training in evidence-based treatment. And sometimes when we have a need, when we're learning, or we can fill a gap, they are very extreme situations, but somebody at the COE might do one of those therapeutic interventions. So bring this back to Olivia. What do we do for Olivia? We would have a triage. A triage means they might send us a referral form, and it always says questions like, what medicine do they need? And so we have a talk. We spend about 15 to 30 minutes with the referral source, typically the Department of Children's Services worker, and to get the story of that child. And then what can we do to help? So for Olivia, we would have had that first talk, and we would have said, we think you could refer this child to parent-child interaction therapy. She's under 2. We can tell you where to get that. But we're going to get her records because, she's a complicated kid. A lot has happened in her little 3 years. We'll get her birth records. We'll get her Tennessee early intervention records. We'll get the CPS reports of what she'd been exposed to. We're going to put that together. We noticed that the grandmother did not follow through with the primary care physician's referrals for speech and OT evaluation. So go back and do that. So we're kind of piecing together some of the pieces that were there, but also supporting that family service worker in getting what they need. So DCS has an education specialist, it's Josh Jones in our region, and we often link back the family service worker to Josh and say, hey, this child could get an assessment with Child Find that will give us some baseline understanding of some of her needs with speech and maybe cognitive delays. So let's link back with Josh and he'll help you with that piece. DCS does all their decision making through child and family team meetings. That's what CFTM is. So the COE sometimes joins the CFTM as kind of expert consultants. So for Olivia, you know, they were having those kind of meltdowns around visitation. So we'll put our heads together with understanding, you know, what goes on during visitation, what goes on after visitation. Maybe we can consult within that meeting to help things go better. And then, of course, our last resort is if we get this best evidence-based interaction piece or treatment PCIT, and we've done all these pieces of assessment, and this child is still struggling, we will do a COE psychiatric eval, comprehensive eval. What else is missing? What pieces aren't working? So that's kind of a typical way that these services would play out with a made-up child but very similar to the kinds of referrals that we get. You know, grounding the COEs is the idea that what we do cannot be just focused on the child. These complex needs are not internal to the child, because we know that trauma affects the child, the caregivers, the biological family, the workers who are working with these families day in and day out with all of these really challenging bad things that happen to kids. And we also know that systems are impacted by trauma. And sometimes some of the dysfunction of what's going on for the child is actually the team is not on the same page, has different kinds of mandates, and aren't all going in the same direction. So the COEs are keeping our eyes on all of those layers. And we think about this as kind of building a safety, a nest of safety to address trauma, so that we're paying attention to the child. The child's embedded in a caregiving system, which can be foster parents and schools. You know, where do kids go? Childcare providers, mental health providers, and then just broader the systems, the mental health system, the health system, the medical system. All of those systems that children are embedded in are all impacted by these challenging things that happen with kids and families. So that's what we call the core services of the COE. And I guess what I get really excited about is that the COEs have a luxury, so to speak, of seeing the needs in the system by having that close-up view of where things are going wrong and what kids can't get. We also get to think together with all of our partners, and many of you on here are partners that we have in different places. So we get to think with our partners about what can we do to enhance and change the system, or where are some of the training needs? And again, doing this in partnership. So Dr. Skatsina talked about the COE Best Practices Collaborative, which started in 2007, which is just that us giving us a fancy name. It's still all the 5 COEs. The state gave us a little bit of money and said, you got this money for 2 years. We want you to train the workforce in a evidence-based trauma treatment. So we're like, okay, we got 2 years to do that. And that's when some of you on here will know we rolled out an evidence-based treatment trauma focused cognitive behavioral therapy. And as we got this training arm, we decided that that work needed a name. So we call ourselves the COE Best Practices Collaborative, but it really is just a loose group of the COEs who plan these trainings and implement these trainings together. So one of the things that the COEs brought when we got that call to action and said, "Hey, train the workforce in an evidence-based treatment," we went to the National Child Traumatic Stress Network to get some consultation about kind of how we should go forward, because we didn't know about this. We were introduced to that implementation science that at the time, training was done. You go to a 2-day workshop, they tell you about this great intervention, and then you go back to your kids and families and you're like all hyped up. That's a great intervention. But there's very little uptake in that kind of training. And so at that time, it was pretty cutting edge that the National Child Traumatic Stress Network had taken the Institute for Health Improvement concept of training and implementation and developed this learning collaborative. And so together with the NCTSN and the COEs, we started rolling out statewide trainings with the learning collaborative model. And many of you have probably been introduced to this by now, but the idea is it's not a one and done training. The teams are trained together in organizations, because to have the new practice stick, we've got to have organizational leadership there. So training involves the agency administrator, a supervisor who's often learning the model together, internal, and clinicians. And over time, we have a trainer who comes in and trains. And then in between the trainings, there people are taking cases. They are getting expert consultation on the model as they're learning it. And so these usually go from 9 to 18 months. So it's a big commitment by organizations to bring these models to their agencies. So we are really appreciative of all the partners, because we brought this a long time ago and folks are still signing on to do this work because they know that it's such valuable training. Here, I was just going to go through some of the models that we've disseminated. If you haven't heard of trauma-focused cognitive behavioral therapy, it is an evidence-based treatment for children exposed to trauma, ages 3 to 17. And it goes through certain components in a gradual exposure way. It is a really important piece of the trauma treatment, and probably it is the evidence-based treatment most available for folks, because we've been training it the longest. We have done 8 full learning collaboratives, and we do these typically East, Middle, and West. But since COVID, we have been able to do take this kind of training model virtual. So we've been able to do statewide trainings. We've had 72 agencies be trained, and over time, more than 500 clinicians. And as you can imagine, as you know about mental health centers, lots of turnover. So continuously, we offer what we call sustainability trainings. If a agency has implemented the model through a learning collaborative, but has that kind of turnover, we offer East, Middle, and West pretty much yearly. So 2-day trainings with that idea that internal supervision is how the folks internally are going to learn the model. So we've done specialty trainings, they're preschool for TFCBT. We've done residential trainings and some specialty trainings for supervisors. So, the work is never done. It's a very important model, and also requires us to continually partner with folks to keep it available. Attachment, self-regulation, and competency, known as ARC, is another one of the models that the COEs have brought to Tennessee. And we are so lucky to have Dr. John Ebert at Vanderbilt, who is one of the ARC trainers for international ARC trainer. And so he's part of the COE and has helped us with all these dissemination efforts. ARC is a trauma intervention framework. It's flexible, components-based. It's for kids and adolescents with complex trauma, those kids who have had multiple traumas impacted them multiple ways over long periods of time. And its flexibility is one of the great pieces of it. because it allows for that kids have so many different ways that they manifest these problems. And so following a components-based model with theories of paying attention to the foundation, which is the attachment, the caregiving level, and then working with regulation and getting kids to have interventions where the trauma robs them of their sense of being competent and able to accomplish things in the world. And so this model really pays attention to all of those healing factors. And it's a trauma-informed model in that it really is paying attention not only to the individual child, but also paying attention to that caregiving system, broadly caregiving system. So not only that parent or foster parent that child's living with, but the school system, the probation system, the other places where kids are, really looking at interventions that support that child's trauma healing, not just in the caregiver relationship or in the therapy relationship. So we've done about 5 of those learning collaboratives. We've partnered with some other folks to bring ARC into agencies. And I don't know, I don't think we have anyone from OmniVisions here, but the OmniVisions is both a statewide company and actually has different other states. And they took this idea of of ARC and have implemented as the conceptual framework for all of their agency functioning, so that everyone is trained in ARC. They run their meetings according to ARC principles. Foster parents are trained. It's really cool. We're going to have OmniVision talk about how they implement this across the whole organization sometime. This is parent-child interaction therapy. I talked about it earlier with Olivia. It is an evidence-based treatment for children 2 to 7. Originally with disruptive behavior problems, but really is an intervention that addresses that attachment issues that trauma really disrupts. It is one of our favorite because we have Dr. Abner here. And of course, when we can get these powerful interventions early on for these children, like we can stop the placement moves, we can kind of treat early those things that we know that trauma has done to kids, and really it impacts them in every way. If we treat them with their caregivers with PCIT, they're going to do better in preschool. They're going to do better in kindergarten. It has this positive snowball effect. PCIT is 16 to 20 sessions. It's very prescribed, kind of skills based with the child and the caregiver. We've done a lot of, this is a map. You can get this map on the COE website from Knoxville. Dr. Berkeley keeps up with it, with the training, but in our region, Frontier Health has a PCIT trained person in every office. Some of them have more than one, and they really have had PCI. Again, I'm always like, hey, go Northeast. We really have probably the most PCIT here, and in Knoxville through Helen Russ McNabb, we just have had a lot. We started earlier, and we've had those folks support that continued training in their agencies. So we're really excited about that. Child parent psychotherapy, you might have heard about it. It's one of the models for children 0 to 6. And it is the gold standard evidence-based model for safe baby court. So COEs worked early and for a long time to bring the first learning collaborative here. We never really had enough money until out of the blue, someone from Children's Hospital had a grant who needed to spend up money, and they'd heard us talking about, plannings like, if we only had the money, we would bring this model here. And so the COEs were fortunate to be able to partner with Children's Hospital on that grant and brought the first cohort of CPP. We have some of it available in Northeast. We really never have as much as we would like, but it's an important piece of the trauma healing. It's healing trauma in relationships with families. And so the COEs are no longer the disseminators of this. The Tennessee First 5 Training Initiative, which is through Allied Behavioral Health, in collaboration with Aim High Tennessee, had a Building Strong Brain grant, and they've been able to do 3 training cohorts that included not only CPP, but some other organizational development for infant mental health in agencies. So we started it, we're still partners, but we're not disseminating that model. One of the ones that we are really excited about, where we saw the gap, one of our psychologist who's no longer in Tennessee, but she was at the Knoxville COE. Her name was Kara Johansson. And she was frustrated by one of the things that the COEs often find: kids whose parents have been physically abusive, they're in custody. The PERM plan says that the family gets, or the parents get, anger management and parenting education, and the child might get TFCBT. There's no family work. So when those things happen, kids go back. There's no work on the family reconciliation and the healing. And we found this evidence-based model developed by Esther Debliger, who was one of the TFCBT developers, and Melissa Runyon, called Combined Parent Cognitive Behavioral Therapy. And it is an evidence-based model for parents who either physically abuse, and it's substantiated, or use really coercive parenting practices. So it's very powerful. We've done 2 cohorts. We wish the first one we did during the pandemic, where we all had to switch to virtual. It's a challenging model, because you really are engaging parents who have hurt their child. At the same time, we know they love their child, and this model brings a way of healing and skill development for parents and reconciliation. So we love this model. We hope that we get some more opportunities to disseminate it. It still is a gap really in our system for folks. So just for kind of completeness sake, these are some of the other projects that we've collaborated with over time. We did a DBT collaboration with Dr. Stinson, who is in the Department of Psychology, and someone who, Dr. Johnson, who was at Cherokee Health at the time, and the COEs, and we tried disseminating DBT. We have not kept it going. There's a couple DBT groups still going. That is still a wide open need that we see in the system, to have more DBT available. The resource parent curriculum is an evidence-based group model for foster parents. So there are still some of those going on with the COEs. We originally brought both the resource parent curriculum and the child welfare training toolkit when we had an National Child Traumatic Stress Network grant, and did a lot of dissemination and worked on trying to have a sustainability after the grant went away. So we weren't as successful as we'd want to, but still opportunities still exist, still a need. We still have our eye on that. And then care, child adult relationship enhancement is, for lack of better, kind of PCIT light. It's really training folks, anybody, parents, case managers, kind of in ways of being with children in supportive ways. And then the COEs have done several projects on children with sexual behavior problems, bringing trainings to the workforce so that folks understand it. This is coming soon. We're really excited about this. This is a partnership. There is a group, the Complex Training Consortium, which is funded by the National Child Traumatic Stress Network, are rolling out these complex trauma modules. There's 20 of them. And their idea was they would have designated trainers that are rostered in every state, and the COEs together made an application for the state of Tennessee. So we were chosen to be the partners with this complex training consortium. So right now, we have 5 COE folks who are getting trained and certified on all these complex training modules. But by probably in maybe by summer, one of the things, in order for us to be rostered, we'll need to do these trainings, right? So that they kind of grade you and say, okay, you're good to go. So we'll be working with some partners on some opportunities to bring these trainings on complex trauma to folks. And then once we're done, then the COEs will be the trainers, so to speak, with all of these modules for folks that partnerships to bring these kinds of trainings to folks. So we're excited because these are, these are the best of the best trainings that are put together, and then the COEs will be able to partner with folks to bring those to them. So those are some of our partnerships, and as Dr. Scatsina, my big gap that kind of I started looking at in 2004 was, what about the little kids? We don't have any mental health intervention for little kids, and that has been my passion, working with the collaborators and community folks and trying to find ways to bring new and innovative ideas to Tennessee. So this slide just kind of looks at some of the places that we've been when we worked for young children at the 2014 to 2015 trauma-informed screening assessment of young children, looking at that idea that we were not measuring trauma in kids under 5. The Department of Children's Services has a assessment tool for CANS, but it only was for kids over 5. And so we felt like trauma was being missed. So we had a breakthrough series collaborative kind of looking at how do you bring that trauma screening and assessment. So some things are better. There is a tool that was developed for young kids. It's like a young kids CANS. It's not widely used in child welfare. It is used with the infant courts. So we are making safe baby courts. So we're making some progress. The COEs, I can proudly say we were really looking at cutting edge models. The safe baby court developed through 0 to 3. We bumped into that and we're like, we need that for Tennessee. So with the Infant and Early Childhood Mental Health Initiative and the COEs, we partnered and had brought speakers in from 0 to 3 and planted the seeds for the Safe Baby Court. We got Senator Hale, who became the champion and actually put this idea of safe baby courts in law. And so Tennessee has, I don't know, like 12 of them now, but the COEs planted the seed, did a grant with CFHI and had the first safe baby court with Davidson County. So some of these things exist. People don't know that the COEs were, at the table helping bring these pieces to Tennessee. So again, this is just the Tennessee Infant and Early Childhood Mental Health Initiative. Dr. Scatsina talked about it. I've just been honored to be, along with my partner, Janet Todd, who is at the COE in Memphis. We had the opportunity to say, hey, what can we do better? And we just became the conveners. And now I think about, how we talk about the backbone of collective impact. But Dr. Todd and I were the one like convening people, bringing together, what can we do? Where are our resources? Where are our goals? We really just informally met grassroots. One of the members was Lorraine Swanson, who was at Department of Health. She wanted to have the endorsement system for evidence-based home visitors. And so she worked along with Department of Mental Health to bring some grant dollars to buy the endorsement system. And we had to have a formal association to house it. And that's how we got CFHI. So we just have this everything that we're doing in Tennessee. And I think that's one of the things Tennessee is great at. We are collaborators and we work together. We don't always have all the resources, but I think we make really good use of all of the resources that we have. We still have a piece of the COEs, CFHI, and TennCare together are the leadership for the Infant and Early Childhood Mental Health and Financing Policy Team that came out of a 0 to 3 opportunity about 3 years ago, and our state sustained it after the initiative was gone through 0 to 3 to develop a state plan for keeping our eye on where we can develop infant early childhood mental health services, how we can better get them paid for. And one of the big is really exciting is Tammy is on here, Tennessee Voices, along with CFHI are working on infant mental health consultation, developing a framework and some some competencies and expectations so that when we get the opportunities to have grants and have infant mental health consultation in settings like pediatrics and childcare, that we have a workforce that we have shared understanding of the expertise. So it's really exciting, something that's and if you're interested, like there's a whole work group and you can get involved in that. Locally, I just added this last night because I totally forgot about this. One of the things that my local COE does, and many people on here have been involved in this, is the COE Provider Collaborative Meeting, which is just a meeting that the COE has convened with child serving folks and some adult serving folks that come around the table every 6 weeks or so and share problems, share opportunities, understanding each other's resources, because as you all know, the child serving system is very complicated, changing all the time, resources are changing. And so this meeting is just a forum for people to come together. And so our COE is like the backbone of that, right? Like we invite people, now it's Zoom, used to be in person, and we just share that information. So if you are ever interested, we have another meeting coming up. You can email me or email Jan. You're welcome to come. You're welcome to come one time. You're welcome to come all the time, but it is a great place for connecting with resources and kind of knowing what's going on. Another piece, COE, ETSU COE is really proud to have partnered with TNAP when they were developing this pediatric foster care learning collaborative for primary care physicians, pediatricians. And so we helped them pull together that pilot and those initial trainings. And that is a project that is still going on. Dr. Fuller in Greenville is actually the leader of the foster care learning collaborative, and also that foster care medical home project, which came after this. But that is still a collaboration that the COEs are involved in. And then there's a small pilot with the COEs with the foster care medical home BHIP program to have child psychiatrists available for medication consultation. These are some other things I talked about, CANS and children with sexual behavior problems, but you're getting the idea that when there are, problems and gaps, like one of the best things the COE can do is come around the table with folks and partner and use resources and use collaboration and creativity to see how can we fill those. I'll highlight the Teen Outreach Pregnancy Program just because there's a couple. So this was DCS had a federal grant partnered with Oasis Centers. The COEs partnered with this as the dissemination partners. So we got to learn a lot about it, but they put this youth empowerment model into residential treatment centers that was developed by Wyman. It was a after school based model, but Tennessee piloted it within residential treatment. It was really cool. The frontline staff are trained in a group that is both skills based, and they have a service learning component where the youth define the problem and fill the gap, so to speak, do the whole project. And the JJR Juvenile Justice Reform Project that Frontier Health has, they actually took that model, and they have brought some of these top groups are in their project here in Northeast, and Holston Home was one of the residential treatment programs, and they still have that top model in there. So again, these partnerships bring these opportunities and really cutting edge innovations. And here is okay, I'll say I'm excited about this, and I'm like, what the heck have we gotten ourselves into? The Center of Excellence in Knoxville and an ETSU Center of Excellence, along with our partners Frontier Health, Helen Ross McNabb, Tennessee Voices, and the SBI, wrote an NCTSN grant in January 2021, which we did not get funded. And it sounded like a really great idea at the time. They didn't give us any money. In October, they said, hey, would you still do this if you had 4 years, and can you do it? And we're like, yeah. And so we now have the opportunity to implement the grant that we wrote in 2021. So I'm excited. And I'm like super worried. Are we going to be able to do that stuff that we said? But we have great partners. And so we're just now getting started. So the grant, when people who've done federal thing, the grant started December 31st. We still don't have a contract, right, or anything. So we are going forward with the project. And the first thing that we're doing, and again, we're always interested in filling the gaps, more services for our younger kids. There is an adaptation parent-child interaction therapy for toddlers. And I've been working with one of the developers, Emma Gerard, for about 3 years, trying to figure out a way to get that here. And we are doing it. Frontier Health and Helen Ross McNabb are going to send teams, and we're having our first training in April. So we're hoping that as of May, y'all can make referrals for PCIT toddler, which is kind of fills the gap in for 12 months to 24. And sometimes, PCIT is for 2 to 7, but if a kid is 2 and rarely developmentally delayed, traditional PCIT doesn't work. So this will also help with our child welfare population. Often kids are delayed, and so while their age is fine, they don't really fit. So this will kind of fill in some of the gaps. And we're also going to bring an adaptation parent-child interaction therapy trauma, which was developed a couple of years ago and researched and just hasn't been widely disseminated. So Tennessee will be one of the first places to have PCIT trauma. We're going to bring a resource parent curriculum, a lot of more infant mental health trainings. And some of the trainings that we do will be broadly disseminated, like some of the foundation trainings about infant mental health. So we will disseminate that. People with Child and Family Health Institute are going to be welcome to come to those kind of more generalized training. So I did it. The COE itself is here in the Department of Psychiatry on the VA campus, but as of April, we're moving out of our building into a place across the road from Johnson City Medical Center. So we don't know what that's going to be exactly, but we will not be here on the VA campus anymore. So that's all I have to say. Are there questions, comments? People have new ideas for projects that we can do?
Wow, this is Martha Wyke with DCSM. It's amazing. I mean, I guess I knew all this at some level, but hearing it like that, you're amazing, Michelle. You guys are amazing. Really appreciate you.
Well, and I agree. Thank you, Michelle. That was so helpful to hear all the history and, how the COEs evolved and how your center here in our region serves individual children, all the training and like you said, is helping systems collaborate. So thank you. Anyone have questions, comments? Feel free to unmute yourself to share these, or if you prefer, you can put them into the chat and I will share them for you.
Hi, Michelle. It's Diana Pure. How are you? I haven't seen you in person in a very long time, but it's great.
I know.
It's great to hear all of that. So thank you for all of your hard work and all that you do with the COE. I had a couple questions, if that's okay. So one question, a couple of questions, they kind of segue, but I'll try not to take up all the remaining time. So I know most of it is kind of medical record review, and yeah, I love the idea of kind of taking a look at the whole picture, and baby steps I will often do the same thing where I'm trying to look at the whole piece, because a lot of times everyone knows their little piece, but nobody knows the child's entire story. And that's even more true once they have been in multiple placements, and I feel like by the time they've been in multiple placements, like no one really knows that child's story, and the child is too young to tell the stories many times. So question is, I know you mentioned if there is a psychiatric evaluation, or obviously if there were to be psychological testing, that they are seen in person. As far as other than that, is the child seen by the team, or is it primarily medical records review? Or does this multidisciplinary team ever have one visit where they kind of look at the child in person from all aspects? And similarly, does Dr. Kitchens at some point see them and kind of take a look at that, or is that from medical record kind of review pieces?
Yeah, so most of the time we're consultants and we don't see the child. It's when we do the psychiatric eval, or when we get to the place where we do the psychological. Most of this is consultation to the team and to the caregivers. So we don't typically lay eyes on the child, except for if we're doing that direct service. So most of the time we're taking other people's reports and records. So that mostly we're consultants. Sometimes we actually see the kid, and I'll tell you, everything is what resources we have, what do we need? I'll tell you that there's been times where Dr. Abner and I went to someone's house to see a kid, not very often, but again, we thought that would save a placement if we could get that kind of consultation directly to the, so we don't do it very often. So mostly it's us consulting to the people who are doing the work with the child. And no, I wish we don't pay Dr. Kitchens. She really just does record reviews, no hands-on. She never sees the kid, and most of that, most of the time, those record reviews come from the DCS nurse, who Susan Smith, who you probably know, who is responsible for all the medically fragile kids that are coming, monitoring, making sure they get. And sometimes she's typically the person who makes the referral to us. She's like, I don't know what's going on with these kids. There's all, these specialty appointments. Can Dr. Kitchens pull it together? And so then we get all of those specialty records and multiple, and she really just slogs through it and summarizes, this is where the kid has had, this is what the kid is need, this is what's missing. So that's the piece that she does for us.
Okay, no, that's great. And then who can refer to the COE? How does that work?
Anybody can refer, but the kids have to have system involvement. So they either have to have open probation case or a child protective service case or be in custody, but there has to be some system involvement. If somebody calls us and they're asked, we can do informal consultations, but our resources are for kids that are in custody or at risk of custody. But sometimes we know some things about service, we don't mind for people to call us and us give them informal ideas or whatever, but the formal referrals for those formal kind of services are kids that have some kind of system involvement.
My last question. Has there ever been conversation about there being kind of a primary pediatric medical home in each of the counties for kids that are in state custody? I know at ETSU Peds, we see lots of children in state custody. And many times they come to us with no records after they have been placed in foster care, or maybe they've been in lots of different medical offices, and then they pop in and there's no. So has there been any conversation about there being kind of a home in each county for children, rather than lots of different medical providers involved?
Yeah, so as you know, when the lawsuit happened a long time ago, it was this EPSDT problem, and they had all the kids go to the health department to get their EPSDTs, and then they would have to come to your practice, right, and have another kind of intake. So Dr. Fuller, do you know him? And it's Ballard, used to be Green Mountain Peds. We're going to want to connect you with him because he worked with DCS maybe 3-4 years ago, I don't know when it was, to do a pilot of his practice being the foster care medical home for the kids in Greene County, so that he does the EPSDT, in the 72 hours, and so he did a pilot. My understanding is there's some other of these. I haven't kept up with it, but I think have the conversation with Dr. Fuller, because he has been the driver of this idea of a foster care medical home. So there may be some conversations about what he's doing that could move your idea forward.
Yeah, it's something it's something I've wondered about for years, just from being a pediatrician and seeing it over the years.
Yeah.
And then I've also been a foster parent, and so I've seen both sides.
Yeah.
Yeah, it's really hard to get the whole story.
Kelly Seltzer, I saw your question. Maybe reflective practice is the bottom. You said the last bullet on the IMPLEX slide.
It started with infant mental health foundations.
Oh, okay. So it should say infant mental health foundations, relationship-based assessment, and reflective practice.
Thank you.
It was like that idea of, we were going to do more infant mental health intervention. So we needed to do that foundational work.
Sure. Okay. Thank you.
And you're on here. You can talk about the infant mental health consultation that I'm so excited about. I didn't know you were on here.
I don't know what else to say that you didn't say, but
All right.
as Michelle said, if you're interested in what's going on in Tennessee around infant mental health consultation, we do have a advisory council that meets monthly to coordinate those policies and practices. So that is open to anybody that is interested in joining.
Any other questions or comments? Okay, well, thank you again, Michelle. And Katie and I would love to help share any of the upcoming opportunities for trainings or groups that folks may be interested in joining. So we will, see if there's anything else you'd like us to send out after the talk or even on an ongoing basis. But thank you again. This was just wonderful to hear about all of your work and all of the exciting work happening in your future projects.
Yeah. We're going to do
it. Congrats. And thank you everyone again for joining us. We will be sending out a feedback survey like we have been doing every month after the collaborative series. Again, try out the new CME process. You will have to answer a couple of questions in order to get your CME in addition to our survey, and give us feedback on the series and on the new CME process.
it.
Thanks all. Have a great day.